Hi, I'm Sioned. I'm the IBS lead dietitian here at Swansea Bay University Health Board, and I recently set up a pilot service to improve care for people with IBS. And today I'd like to talk to you a bit about how I've used patient-reported outcomes and experience measures as part of that process. Next slide, please. Thank you. So just to give you a bit of background, IBS symptoms, as we all know, can be quite debilitating and can significantly affect a person's quality of life. We do still hear some quite unhelpful terminology when people are talking about IBS. For example, even within healthcare, people will often say things like, "Oh, it's just a bit of IBS," which really isn't very helpful for people who are going through it and whose symptoms might actually stop them from holding down a job, leaving the house, being able to maintain an active social life. So I suppose it's just important that we don't underestimate the effect that IBS can have on someone's life. And for many people as well, sadly, the first line dietary changes which is what we as a dietetic service were mainly able to provide prior to this pilot, don't always achieve adequate symptom improvement for people. However, this pilot service that commenced back in September 2020 is now providing more specialist dietary advice, including the highly successful low FODMAP diet. And the low FODMAP diet is actually successful in about 75% of people with IBS who try it. So that is really positive. Next slide, please. So the main aims of the project are firstly to bring the service in line with the British Society of Gastroenterology and NICE guidelines for the treatment of IBS. Also to provide timely intervention to improve symptoms and quality of life. Timely being the key word there. A lot of these patients will wait for years on end to see a gastroenterologist or have invasive procedures to investigate to confirm that diagnosis of IBS. So now that this service is available, people can come to see us in the meantime, and in most cases we then manage to improve their symptoms, and they then don't need to go on for those gastroenterology or endoscopy appointments. So that, of course, helps the patient's experience, most importantly, but also helps to reduce costs within our services. It helps to reduce referral to treatment times within secondary care as well. There's also a bit of a revolving door situation going on in primary care, where people keep going back to their GP over and over, because of course their symptoms aren't necessarily getting any better. They're trying various medications. Some of those will then have side effects, and understandably patients and GPs will both find that quite frustrating, and it's not a very good use of anybody's time. So that's another area that we're working to improve on as well, as part of this service. I think the big one really is empowering patients to self-manage their IBS. So far there isn't a cure for this condition, so patients will inevitably, most of them have flares again at some point in their lives, but the key is that they will now have the knowledge and the skills to manage that flare themselves in a lot of cases, and bring their symptoms back under control. Next slide, please. So to tell you a little bit about the journey so far, there was a small dietetic pilot in Bridgend back when we were under ABMU Health Board. which demonstrated significant improvements in symptom control and cost savings. So that pilot involved about 20 participants, so it's quite a small cohort, but they found that they actually had a reduction of about 55% in prescribed items during the year post-intervention in comparison to pre-intervention. So that's really positive, and it added up to about £250 of savings per patient per year on medication use, which if we extrapolate that figure to cover our referrals in Swansea Bay, that adds up to about 25,000 of potential cost savings on medications alone in Swansea Bay. And we've also, from this, from some of the data from the current pilot, worked out that there's a potential to save about 45,000 a year just on reducing the number of invasive investigations that patients go through to confirm that diagnosis as well. Going back to that previous pilot in Bridgend, the dietitian who ran that was appointed as a Bevan exemplar, and several spread and scale projects came out of that and were really successful as well, demonstrated similar results. The implementation of the low FODMAP diet, going back a few years now, was actually a DOTS priority, and we've been working hard just to get the funding to be able to get that ball rolling, really. So we've got temporary funding now, and we're working to extend that. There's substantial national and local evidence of cost effectiveness. I've covered the local already, but there's other services across the UK that are providing the low FODMAP diet. One of which is the IBS service in Somerset, which is fantastic, has been established a lot longer than we have, and we did some benchmarking with them and took on board their advice based on their experience of running a similar service. So that's been really helpful as well. Next slide, please. So funding was secured for the current pilot. We started back in September 2020. It was initially going to be for a year, but we did manage to get some more temporary funding for another 6 months. So at the moment, it's going on until the end of March, and we're working on business cases to extend that. It's been really useful to be able to involve primary and secondary care in the planning and agreeing pathways together with them to make sure that our aims are aligned and that we're all working towards a common goal. And we've done that through the gastroenterology working group. We try to meet monthly, and through that we've also been working alongside another pilot which provides access to fecal calprotectin testing in primary care within the same cluster that we're working in. So that means that the GPs can actually send the samples away for testing themselves rather than having to refer the patient to gastroenterology to have this done. And that's just if they have a suspicion that it could be IBD, so for example Crohn's or colitis, rather than IBS, is to rule that out. So it's a much faster process for the patients, and there's obviously less referrals then going into secondary care as well, which is brilliant. Next slide, please. So of course the main purpose of this session today was to talk to you about how we're using patient reported outcome and experience measures. We're using these to evaluate the interventions and to inform business cases to extend the service. I think it's really important to us that the outcomes we achieve are outcomes that actually matter to our patients. So a lot of thought went into making sure that we were collecting the right outcomes, really, not just what we thought we should collect, but what our patients thought that we should be collecting. And that's why we ended up using a validated tool, which I'll tell you a bit more about in a bit. Patient engagement as well is really key to the success of this service. If we don't get their engagement in terms of reporting these outcomes and experience measures, then we just don't get that data to put into our business cases. So it's incredibly important within this service especially, and of course just for improving the patient's experience, which is the main reason. So previously, when we've attempted to collect PROMS and PREMs elsewhere within dietetic services, we've found this quite challenging. So in the past, we've used paper forms and handed them to patients or posted them or emailed forms out to them, and engagement has just been really poor because of, I suppose, the effort that's required there from the patient, who in a lot of circumstances aren't feeling up to it. So that is really the main reason that we went digital. So there were some concerns when we were considering going down this route about whether we'd be reducing inclusivity by going digital, but I must say it's actually worked really well. So the patients receive a letter when they're first accepted into the service that asks them to expect a text or an email with the forms included, and to phone us if they either don't receive them for whatever reason, or if they are unable to access forms online. And actually only about, or less than 10% of our patients are needing to phone us to complete the forms with us over the phone. Most of our patients have been really independent with it and just got on with it themselves, which is fantastic. Next slide, please. So to give you a bit of an overview of what the service actually looks like, as I've mentioned, the purpose of the service is to provide more specialist dietetic advice to people with IBS, including that low FODMAP diet. And we do this via one-to-one and group sessions, depending on what suits the patient best. So the digital assessments, the forms that are sent out, are then used in 3 ways. So if you look at yellow circle number 1 on the diagram, that represents our triaging form, and that is sent out. So the digital platform we use links to our digital waiting list, and as soon as a patient is added on to that waiting list, the next day they will get a form automatically sent out for them to complete. And that form gives me information about their medical history that may not have come through on the referral, so that I can screen for red flags, and just assures me that they are coming into the right service. And it also helps me to decide whether that patient would be better placed in a one-to-one session or a group session. So yellow circles 2 and 3, those represent our outcomes forms. So for that, we use a validated form. The one we use is the Functional Gastrointestinal Disorders Symptom Evaluation Form by King's College London. And that gives us some really detailed information about the patient's symptoms. So it's sent out a week before each appointment, so that I can clearly see the difference from pre-intervention to post-intervention, or even at intervals during the intervention. And I think the key is that I actually use those forms, the responses to those forms within the appointments as well. And patients really see the benefit of it. Then it's a nice visual for the patient to see exactly what's changed with their symptoms, because they do sometimes struggle to describe what's changed otherwise. Yellow circle number 4 then is our patient reported experience measures form, and we use that to monitor long-term adherence and patient satisfaction, and then of course any constructive feedback that is provided to us through that form we then act on to improve the service, and that is sent out 3 months after the patient's discharged from the service. Next slide, please. So here are some of our results so far. So the image on the screen is part of a report that is pulled from the platform that we use. So a member of the value-based healthcare team very helpfully does that for us and produces these very easy to read images for clinicians like me to make it really easy to see what's going on. Just to explain the color coding on that chart there, the green represents symptoms that patients are reporting that they're either not experiencing at all or perhaps experiencing very rarely. Yellow is occasional or mild symptoms. Orange is moderate, frequent symptoms that are affecting some social activities. And red are severe symptoms that are continuous and affect most social activities. And as you can see, there's a lot more green on the post-intervention image and a lot less red, which is really good to see. And we can see that across the board as well. So looking at the overall symptoms as well as each individual symptom, there's improvements across the board there, which is lovely to see. Next slide, please. Here you've got some of our key benefits measures. So the most relevant of which are highlighted in red there. So that's our completion rate of the forms, which is particularly high just because of the way we've there was a lot of careful planning that went into making sure that these forms were integrated directly into that patient care pathway, and that the patients also could really see the value of them, the value of completing them and giving us that information. We've also got our referral to treatment time there, or days to first contact. And we've got the notional clinical time released. So we worked out that just by using these digital forms, I'm actually saving 25 minutes per patient, which actually, when seeing as it's only me running this service, I'm the sole clinician in this service, that actually makes a huge difference, and it's saved about 46 hours of my time during a 6-month time period, which makes a huge impact on my clinical capacity. Looking at the graph underneath, you can see when it changes to dark blue, that's when I started in this post back in September 2020. And we spent a few months obviously getting the service set up, agreeing pathways, sort of testing these forms as well and making sure that they were as patient friendly as they could be before we went live with the digital collection. And then we went live in February, and you can see when we get to February on the graph that there's quite a steep reduction in our days to first contact, despite us also having quite a steep increase in our referral rates around the same time. So to sum that up, we're seeing more patients than we were previously, and we're seeing them much sooner as well. And that really is down to using these forms as well as having group sessions as well. Next slide, please. So we had quite a basic question on one of the forms that just asked the patients, have you been able to reduce your medication use as a result of an improvement in symptoms? And as you can see, so we've excluded the NA responses because, of course, some patients weren't on relevant medication. But of those who were on relevant medication, most have said yes, that they have managed to reduce them. And we are collecting more robust data from directly from GP databases to further prove that that reduction and get some more financial data on that. You can see another thing we've been looking at is bowel action frequency, which of course is very important to most people with IBS. So before the intervention, we can see that patients were having to open their bowels 7 or more times a day, or in some cases as infrequently as once a week, which of course causes a lot of discomfort and has a real impact on quality of life. And after the intervention, we can see that most patients, bar one there, are within what we'd consider the normal range then of once every 2 to 3 days to 2 to 3 times a day. So a much more manageable frequency for the majority of our patients there. We had a bit of a happy coincidental finding. I included a question about current stress and anxiety levels, partly because I was interested to know, with the low FODMAP diet, it is quite a it's a lot for people to take on. It's very restrictive and it's a lot to learn. It is quite complicated. So I was interested to know what effect that would have on people's stress or anxiety levels. But it was actually really nice to see that we're somehow having a positive effect on stress and anxiety levels. And that, I suppose, just goes to show the effect that improving someone's physical health can have on improving their mental health as well. So it's great to see that we're having a broader impact on people than we expected. Next slide, please. So what have we learned from this process? So our early results show some really positive improvements in symptoms, as you've seen, as well as cost savings in terms of medication and reducing invasive procedures, as well as reducing the referral to treatment times within secondary care and within our service as well. These digital assessments have actually reduced my admin burden by about 25 minutes per patient, as I mentioned, which is about 46 hours of my time over 6 months, which has a huge impact. And using those group sessions as well to make more efficient use of clinical time and resources. We have very low DNA rates in the service. I think that's largely due to the platform we use sending out reminder texts before the appointments. But I think the forms in themselves do act as a bit of a reminder as well, especially as they're being sent out just a week before each appointment. It sort of reminds patients that they have an appointment next week as well. We've been supported by the value-based healthcare team throughout this process, and I can't begin to explain how helpful that's been. I don't think we'd have actually done half of what we've done without their support. So if any of you are listening, thank you so much for your help. Having the collaborative approach with primary and secondary care through the gastroenterology working group has been really useful as well, building those connections that we perhaps otherwise wouldn't have had much chance to build, and just making sure that our goals are aligned and that everyone's in agreement with the approach that we're taking. So that's been really useful. There have been some challenges to overcome with regards to data availability. So that's predominantly, so when we're trying to collect data to prove the reduction in medication use and the reduction in repeat appointments in primary care, there have been challenges with how IBS is coded on the primary care databases. So looking at vision and EMIS, for example, I have access to those for the GP surgeries I cover. But if you look at a person with IBS's records, you'll see that they'll have had a conversation regarding their IBS. In the description, the doctor will have written, for example, a patient experiencing a flare of IBS. However, that consultation will have been coded as any number of things. It might be diarrhea, abdominal pain, constipation. There's a long list of things it could have been coded as. And of course, if we then do a search for anyone who's had diarrhea, we're going to have all sorts of different conditions coming back, not just IBS. And the same goes for some of the medications that are used to treat it. They're also generally used to treat a lot of other conditions as well. So there have been challenges. I know the value-based healthcare team haven't managed to get access to the sort of behind-the-scenes data that they would like to be able to access either. And I think that's potentially due to information governance, but that's something that would really make a difference moving forward if we could get better access to that data in primary care. Next slide, please. It's worth mentioning as well that I think the main reason we've had such good engagement from our patients is because we've integrated the forms into their care pathway, so that in order to get an appointment, they have to fill in a form. And that gets the ball rolling. Once they've filled that first form in, then they're familiar with the process and they're more than happy to complete the other forms. But I do think that has made a difference in terms of engagement for anyone who's looking into doing something similar within their services. I think that's something really useful to bear in mind. Looking at future work, so we're going to continue collecting patient data and using evidence from the improved patient outcomes and cost savings that we're seeing to extend the service. Information from primary care services is being collected to evidence reduce medication spend and repeat GP appointments as well. And we're also planning to provide further education to referrers in order to improve adherence to the guidelines around diagnosis and treatment, and just making sure that wherever possible we're avoiding those unnecessary referrals to gastroenterology or endoscopy. It's also worth noting that we've been shortlisted for the Award for Digital and Technology Innovation in the Advancing Healthcare Awards in Wales for this work. So if anyone's attending in a couple of weeks, I'll hopefully see you there on the screen. And I think that's it, really. I think you've all heard enough of my voice. So I suppose it's time to answer any questions.
Thank you, Sioned. That was really interesting. And congratulations on the awards nomination as well.
Thank you.
Shout out to you from your local Swansea Bay value-based healthcare team on the chat as well. So they're obviously listening in. There's a question here that's just come in. How do you, as a clinician, influence the sharing of the data from primary care? Because we all know that it's so critical, but it's so hard to get hold of.
I think that's been our biggest challenge, I'll be honest. I think I was lucky in that I think that gastroenterology working group that we're a part of has been really helpful, so that the key people are aware, I suppose, of what we're trying to do and how it would benefit them to help us to get this information that we need. I did quite a bit of nagging to get some to get remote access to Vision and EMIS, the GP's databases, and that has been absolutely invaluable. It is very much a case of trawling through the data. So, for example, 6 months after a patient is discharged, I will go back onto their records in the GP system and look at what medication that individual patient is prescribed. So I think there's many ways in which it could be improved, but we're just working with what we've got really and what we can access. And I think being really organised as well, with making sure that we're collecting what data we can from the patient in the consultation does help as well. Does that answer the question?
Absolutely, and I think very good answers, yes. I have a question for you, if you don't mind. How have patients responded to the changes, and did you get any resistance to the change from either patients or any of your colleagues?
So it's all been really positive, actually. I think we've had one patient so far who wasn't happy to complete the forms for because of the data privacy sort of concerns that they had. Everyone else has been more than happy with it. We've had really good uptake from patients, a really good response. I think patients, I think they quite like using it, especially the reporting their symptoms, because I think it does help them to feel listened to, that we're looking at that level of detail on their symptoms. And it's particularly helpful when I'm running group sessions, just for the patient's own comfort. I don't ask them to discuss their symptoms within the group if they don't want to. They're welcome to if they want to, but they don't have to. So it's for that to happen, it's key that I've got that information before the group. So it does improve the patient experience in that sense as well. And in terms of staff, it's been, yeah, we've had no concerns from staff really. Only the concern that we all had, I suppose, in the beginning of whether we'd be sort of reducing that inclusivity by going digital. But I think it's also been helpful that my cohort of patients tend to be younger, so just in terms of when IBS is usually diagnosed, it's only a small percentage of my patients are sort of older patients where they perhaps might not have the experience of using technology quite as much. So yeah, we've had really good responses all around, actually. And so the reports that we get from the system as well have just been, I think they've received some really positive feedback. So when we've presented, sort of promoting the work that we've done, or presenting to stakeholders, then they've all really enjoyed looking at those reports and commented on that as well.
Sioned, one last question from me, if you don't mind. With the power of hindsight, what is your greatest learning and what would you do differently?
I think in terms of using the digital assessments, I think our greatest learning, or what we'd sort of pass on to others, is just think carefully about how you sort of structure, you know, when these forms are going to be sent, and and how you make sure that patients engage with them. So for example, like I said, patients have to fill in that triage form before they get an appointment. And I think that's really been key to engagement in our service. And I was a bit worried about setting that up at first, because I had a fear, I suppose, that patients wouldn't engage and that we'd lose numbers from the service, or that people would miss out. But actually, if they're not comfortable with doing that, they just phone us, as we've stated in the letter for them to do, and that works really well. So I suppose that's our biggest learning. In terms of what we do differently in future, I think I would probably look at getting access a bit earlier to the medication data and the primary care appointments data, just because I think it took a while. Initially, I tried arranging to go into the GP surgeries, to log into their computers there and do it that way. But that was obviously more time consuming, and logistically it was quite difficult, what with COVID and social distancing and everything, that it did raise some issues. So, and actually when we did try and get that remote access, it was quite an easy process, and I thought it would be a lot harder. So I think that's something we'd do differently in future. I think that's the main thing, really.
There's a question here from Kenneth. How did you find developing the bespoke triage form, and what was that process like?
So that was completely based on clinical guidance, so it was quite easy to do. What I wanted to make sure was that we weren't missing any, especially as we're running groups, so you do sort of miss out on some of that that conversation with the patients there, that we weren't missing anything from their clinical history that might be a red flag, because there are some risks with some of the interventions we offer, that we could essentially mask some conditions if we improve the symptoms, without them having first had the appropriate investigations, like celiac screens, for example. So that was my main aim, was just to make sure that we're getting that information, and that was purely based on the clinical guidance. So that was easy enough to do. And the other thing we did, so we did have some guidance from the dietitians at Somerset, so they were really helpful. They had done something similar. I think, if I remember that right, there was more in the form of a self-referral type form, if I remember right. But I did have a look at that, and so it wasn't completely done from scratch, if that makes sense. So I took note of what they were asking in terms of what patients had already tried with their diet and that sort of information as well. So I suppose benchmarking was really key to making that process easier as well.
Thank you. And coding is something that we see across the board being raised, and obviously primary care coding is slightly different again, isn't it? And it very much depends on local capacity. You mentioned in your talk that you have access to some of your local GP practices and access to the services. Do you think that is going to have an impact on the coding, the fact that you have that closer interaction with them?
I think it's quite difficult to have an impact on that. I think longer term, there's a chance that we could, in terms of if we, as I said, we're planning on doing some more education sessions. So if we could incorporate a discussion about coding as part of that, and just encourage them to always use the same coding, to always use IBS or whatever they're more comfortable using. But I don't think we'll have a completely, not from my side of things anyway, I don't have the skills or the knowledge, I'm afraid, to have a huge impact on that front. But there's certainly room for improvement through education and discussion as we move forward. We've had challenges in it being a temporary service at the moment as well. But yeah, watch this space.
I'm just having a quick look, and I don't think there's any more questions. Thank you again so much. You've been an absolute star, and the data that you showed, any change that you made with your service has been outstanding. So thank you so much.
Thank you so much for inviting me to speak as well. I think it's really important that we get opportunities to share our practice with others, so that, you know, the improvements that we put in place can actually have a wider impact, isn't it, and help other services. So thank you for this opportunity as well.